Almost 1/3 of the world's population has iron deficiency anemia. Iron deficiency refers to decreased total iron body content, and anemia is defined as a decrease in the number of red blood cells or the amount of hemoglobin in the body. So, iron deficiency anemia basically refers to the condition where iron deficiency is severe enough to diminish erythropoiesis and cause the development of anemia. Hemoglobin, as we know, is made up of 4 heme molecules which have an iron molecule at the center, and this iron binds oxygen. So low iron levels would mean reduced hemoglobin synthesis and reduced oxygenation throughout the body, leading to fatigue and breathlessness. The depletion of iron stores in the body can result from several reasons. The first is blood loss, which could occur in premenopausal women due to menstruation, or the blood loss could be from the gastrointestinal tract resulting from parasites, as seen in hookworm infestation. The second cause is increased demand that occurs in states like pregnancy or during the growth phase. The third cause is decreased absorption of iron, which can occur in patients who underwent gastrectomy or in patients having gut pathologies like sprue or celiac disease. Also, a diet predominantly containing vegetables contributes to iron deficiency. The symptoms of iron deficiency anemia are usually nonspecific and include fatigue, breathlessness, pallor, and palpitations. However, the well-known clinical features are generally only seen in cases of very long-standing iron deficiency, and these include brittle nails, spoon-shaped nails, also known as koilonychia, atrophy of tongue papilla leading to a smooth tongue, and of course, angular stomatitis. Plummer-Vinson syndrome comprises of a triad of anemia, dysphagia, and glossitis, and can occur in long-standing cases of iron deficiency anemia. The diagnosis of anemia relies on a clinical history which should include questions about the dietary intake, self-medication with non-steroidal anti-inflammatory drugs, since these drugs may give rise to gastrointestinal bleeding. Presence of blood in the feces may be a sign of hemorrhoids or carcinoma of the lower bowel, and the duration of menstrual period and the occurrence of clots in premenopausal women. Let's take a look at the important investigations that can help diagnose iron deficiency anemia. The first is blood count in film, which reveals that the red cells are microcytic, that is, mean corpuscular volume is less than 80 femtoliters, and that the cells are hypochromic, that is, mean corpuscular hemoglobin is less than 27 picograms. Poikilocytosis, that is a variation in the shape of RBCs, and anisocytosis, that is a variation in size of RBCs, are also seen. The next important investigation is serum iron and total iron binding capacity, or TIBC. Serum iron falls in iron deficiency anemia, whereas TIBC usually rises. Another measurement, called the transferrin saturation, is the ratio of the serum iron concentration and the TIBC expressed as a percentage. Transferrin is an iron-carrying protein, and since in iron deficiency anemia, the iron levels are reduced, there is a decrease in the transferrin saturation. A transferrin saturation of less than 15% is usually seen in iron deficiency anemia. The number of transferrin receptors increases in iron deficiency. This assay can help distinguish between iron deficiency anemia and anemia of chronic disease. Another important investigation is serum ferritin levels. The level of serum ferritin reflects the amount of stored iron. Roughly, the normal value in males is 30 to 300 micrograms per liter, and about 15 to 200 micrograms per liter in females. In simple iron deficiency, a low serum ferritin confirms the diagnosis. However, ferritin is an acute phase reactant, and levels increase in the presence of inflammatory or malignant disease, as well as in the presence of liver disease. Other specific investigations may be required to find out the underlying cause. For example, in patients with GIT pathologies, investigation of the gastrointestinal tract is required. The presence of anemia with microcytosis and hypochromia does not necessarily indicate iron deficiency anemia. That makes it a little tricky. This table here shows the differentials of iron deficiency anemia and how to rule them out. Let's have a look. The mean corpuscular volume, or MCV, is reduced in iron deficiency anemia, is low or normal in anemia of chronic disease, is very low in patients with the thalassemia trait, and is low in the inherited type of sideroblastic anemia and raised in the acquired type. Serum iron levels are obviously reduced in iron deficiency anemia, as well as in anemia of chronic disease. However, serum iron is normal in cases of thalassemia and raised in patients with sideroblastic anemia. Serum TIBC levels are raised in iron deficiency anemia, reduced in anemia of chronic disease, normal in cases of thalassemia as well as sideroblastic anemia. Serum ferritin levels are reduced in iron deficiency anemia, normal or raised in anemia of chronic disease, normal in thalassemia, and raised in sideroblastic anemia. Serum soluble transferrin receptors are increased in iron deficiency anemia, normal in anemia of chronic disease, and normal or raised in thalassemia as well as sideroblastic anemia. The correct management of iron deficiency anemia is to find and treat the underlying cause and to give iron supplements to correct the anemia and to replace iron stores. Oral iron is all that is required in most cases. The best preparation is ferrous sulfate given orally. If the patient has side effects such as diarrhea, nausea, or constipation, taking the tablets with food or reducing the dose using a preparation with less iron, such as ferrous gluconate, may help reduce the symptoms. Oral iron should be given long enough to correct the hemoglobin level and to replenish iron stores. This can take about 6 months. Common causes of failure to respond to oral iron include lack of compliance, ongoing hemorrhage, and incorrect diagnosis such as a thalassemia trait being misdiagnosed as iron deficiency anemia. These possibilities should be considered before parenteral iron therapy is started. Parenteral iron is usually required in cases where patients are intolerant to oral preparation, patients present with severe malabsorption, or where patients present with a chronic disease such as inflammatory bowel disease. Parenteral iron can be given by slow intravenous infusion, and the preparations available include low molecular weight iron dextran, iron sucrose, ferric carboxymaltose, and iron isomaltoside. Oral iron should be discontinued for such patients.